Medical Branch in Galveston's Aerospace Medicine Residency Program Grand Rounds. And I want to thank all of our participants this morning. In particular, thanks to Dr. J.D. Polk for suggesting that we invite Dr. Sinclair to speak this morning. Thanks to Rachel Fowler, who coordinates our Grand Rounds and has organized all these activities. There are a few things that I'd like to do before I introduce our speaker this morning. First of all, I'd like to remind everybody to mute their microphones. It's quite distracting if there have nearly 100 participants with noise in the background. And also, if you wouldn't mind, please disable your video cameras. It's much easier on the bandwidth, particularly if the presenter has a motion video. It's easier for us to receive it. And what we would like to do is for you to save questions to the end of the hour. Dr. Sinclair will leave time for that. And one unusual little quirk here, at the last minute, we found that we're not able to provide CME credit for this session. Had to do with the way Baylor handles CME credit, and they were not able to approve it for this particular session. And so we apologize for not getting that information out to you sooner. But there will be no CME credit for this session. So with that, I would like to introduce Dr. Sinclair. We're very honored to have Professor Sinclair with us this morning. Professor Sinclair graduated from the University of Birmingham, England, School of Medicine in 2000 with honors and attained her MRCP in 2003. She completed her PhD in 2010, funded by the Medical Research Council Clinical Research Training Fellowship. Subsequently, she worked as a National Institute for Health Research, NIHR, clinical lecturer in neurology, and then an NIHR-funded clinician, scientist, and neurology consultant. She leads a translational research group which seeks to establish and exploit the pathophysiological mechanisms underpinning the debilitating effects of metabolism and intracranial pressure on headache, develop therapeutic strategies, and generate real impact on improving patient care. The translational portfolio also encompasses a clinical trials program enabling forward that is novel therapeutic molecules under assessment in patients, and back translation, and that is biomarker evaluation in the laboratory setting. She leads the multidisciplinary clinical headache service and idiopathic intracranial hypertension service at the University Hospital NHS Foundation Trust in the UK. Professor Sinclair is on the scientific committee for the North American Neuro-Ophthalmology Society, NANOS, and a member of the board of the International Headache Society and the European Headache Federation. In the UK, she's the deputy chair for the Association for British Neurologists, Grouping for Headache and Pain, ABN-AAG, and a council member for the British Association for the Study of Headache, which is BASH. She's on the research committee for the Association for British Neurologists, and we are very pleased to have you speak with us today, Dr. Sinclair. I'll turn it over to you, and I'll pick it up at the end of your presentation.
No problem. And thank you for my introduction, and thank you very much for inviting me to speak. I'm just going to put my screen share up. So I hope that my slides are now sharing for you all. I'm just going to move that over there. Perfect. So it's a real delight to have an opportunity to talk to you all this morning. I had put up some questions for CME, but maybe if we're not officially talking about CME, I'll move past those. And really, I wanted to introduce where I was from. So I'm from Birmingham in the UK, and I work between two institutions, as you've heard, between the university. Oh, hang on, my slides are not moving. Work between the university, pictured on the left, and the hospital on the right, where we run a large service, probably one of the biggest in Europe, for idiopathic intracranial hypertension and raised pressure disorders. So half of my week I really work as a consultant clinical neurologist, and the other half of my week firmly at the university, doing much more on the research side, really from very much basic physiology and basic science through to trials. And the work is very interdisciplinary, and I'm very lucky to have a brilliant team in Birmingham that encompasses a lot of very basic neuro-ophthalmic research, computer modeling, trials expertise, and drug discovery. But to focus where we're talking about this morning, so I wanted to introduce to you a concept that we tend to call clinically pseudotumor cerebri. And it is a concept clinical diagnosis which encompasses many conditions where there is optic nerve swelling, a term that we call papilledema. And in the setting of this, we would see fluid shifts and typically raised intracranial pressure. And that raised intracranial pressure could be to a mild degree, a moderate, or a more severe degree. And these are disorders of CSF dynamics. And I've drawn a sort of schema here to really put the picture of where you might imagine SANS at the bottom in orange, and where I sit as a clinician with all the other conditions that can appear a bit like SANS. So at the top of the tree, we have intracranial hypertension. To the left, we have idiopathic intracranial hypertension, one of my particular expertises and interests. And on the right, we have other secondary causes of fluid shifts and intracranial hypertension. And here there's quite a few different ones. These conditions can be caused by hypercellular cerebrospinal fluid. So that's very high cells like we might see in malignant meningitis or in a Guillain-Barré syndrome, by anemia, by venous thrombosis, and a very similar constellation of features we see in SANS, as we're going to talk a little bit about. So I wanted to highlight here that there are many causes, but all of these conditions have very similar consequences on the brain and optic nerve. And that is because all of these different conditions can act in different parts of the fluid dynamic system of the brain, whether they dysregulate fluid primarily through hormonal or obesity factors such as IIH. They result in raised pressure in some of these conditions. There is predominant venous compression in other conditions, which can reduce outflow from the brain and reduce CSF absorption at the arachnoid granulation tissues. So, for example, the CSF hypercellular conditions, like I mentioned, malignant meningitis causes reduced CSF absorption. There are other conditions where you get raised pressure within the abdomen, which causes venous outflow obstruction and venous cephalic shifts. So many conditions, all working on a similar system, with very similar consequences, but different causes. Now, I'm not an expert on SANS. Many of you in the audience will have come across this condition much more than I have, but as I have had discussions with a number of members of your departments and other space departments within the UK, and the literature would point us towards a secondary condition of raised ICP or fluid shifts, where we have a setting of microgravity, a condition that tends to get worse with the more prolonged the space flight is, and where we see increased fluid on brain and ocular imaging techniques. And I've just picked out two of the papers just to really highlight that. I think these are two of the more recent papers that have come through. The first is the Ocular Health ISSS study of astronauts, which was a longitudinal progressive cohort study over SANS, studied over 6 months on board the ISS. And we see this clear progression here where the OCT imaging, which I'm going to talk about in a bit more detail, shows increased swelling of the optic nerve with the more prolonged space flights, which remains once the astronauts come back down to Earth and then starts to resolve. And this occurred in 10 out of the 11 studied in this prospective study. And then another recent study here, just my slide on, was an MRI study where we had again prospective data from 11 cosmonauts during spaceflight with a mean spaceflight of 171 days, and very clear evidence that after they landed and were re-imaged by MRI, there was increased brain volume and fluid volume, that's cerebrospinal fluid ventricular volume, and that this was quite prolonged. It remained at 1 year post-imaging. So the salient features of this condition SANS, which you will hear about, is that there are ophthalmic and brain manifestations. The ophthalmic manifestations at the top are the optic nerve edema, other eye features such as choroidal and retinal folds, and even infarcts of the retina, which we see as these things called cotton wool spots, little white areas on the optic nerve. And the data showing us that within the brain, there is increased fluid volume, but also studies now showing that there is venous congestion, that's collapse of the venous sinuses, and a case of thrombosis. And also the imaging data coming back from NASA research is showing us that there are increased white matter lesions on the brain MRI scans. And in many cases in terrestrial medicine, we know that that's a heralding feature to give us an increased risk of stroke and dementia in the future. So how does the two conditions, SANS and other causes of intracranial hypertension, relate to each other? Well, I've mentioned that both have optic nerve edema. Both are complicated by altered cerebral fluid dynamics and probably elevated intracranial pressure, certainly in IIH, possibly to an extent in SANS. And all carry potentially, therefore, this risk of blindness due to the optic nerve edema. Now, I wanted to come back to set the scene a little bit more about what I do as a specialism. So in my hospital, we run a really large service for IIH, idiopathic intracranial hypertension. And this is very different to SANS in many ways. It's a condition, again, of raised pressure and fluid shifts and optic nerve swelling. But this time, the condition is occurring almost exclusively in young, obese women of childbearing age. And these women tend to present with headaches, which takes them to the ophthalmologist, where we would discover the optic nerve swelling. And up to 25% of these patients will have permanent severe visual failure. We have very strict diagnostic criteria. They all have to have this papilledema, i.e. the optic nerve swelling, otherwise a normal neuro exam, normal neurological brain imaging, except for features of raised pressure, normal CSF composition, and a high pressure on lumbar puncture examination. And they all have venography to exclude a thrombosis. So what's the relevance of this to the grand round that I'm giving for you today? Well, I think there are a number of things we can learn from our knowledge of IIH. I think the cause of IIH is not so relevant. This is a very different cause to the cause of SANS. But as I've mentioned, the consequences of IIH in terms of the consequences for vision, the consequences for venous thrombosis, potential consequences for headache and cognitive dysfunction may be relevant. So I want to tell you a little bit about where our research and clinical practice has taught us about IIH. So the risk of blindness can be quite high. The optic nerve edema carries about a 24% of permanent visual loss in some studies, and in more recent studies in more high throughput centres, this risk is less. And the main modality that we use to diagnose, monitor and track our patients is OCT imaging, which I'm going to come back to. But the main point that I wanted to make from this slide is that we know from our literature in IIH, the longer the optic nerve edema occurs, the greater the risk is of permanent visual loss. And there are a number of reasons for that. The optic nerve, I tend to imagine it as a bit like an electrical cable with multiple wires running through it, as you might imagine the optic nerve here at the back, a bit like an electrical cable. And in pressure conditions or in fluid shift conditions, you get increased pressure on the optic nerve due to increased fluid pressure here. That compresses those axons within the optic nerve, and they start to become ischemic and can ultimately die. And once an optic nerve axon has undergone apoptosis and death, it cannot be recovered. And obviously, the more axons that die, the greater the degree of visual loss, and the greater the degree that that visual loss will be noticeable to the patient. So hence, if we intervene early in our patient group in my clinics, we can prevent early visual loss, which is what we're aiming to do as doctors. And we worry about the chronic optic nerve swelling because of the propensity of permanent irreversible visual loss. So I wanted to give you an example of a 39-year-old lady that I saw with IIH. And in the top panel, A and B, she has some really very mild optic nerve swelling, and her vision was stable, and we weren't worried about her. And her visual fields, as you can see on the right, are only very mildly impaired. But for one reason or another, she'd had this for quite some time. She decompensated. And when I saw her again at about a year down the line, she had rapidly declined, and she was developing obscurations, which means blacking of her vision. And her optic nerve swelling, even if you're not a doctor, I think you'd see was very different between the top panel and the middle panel, where we had this blurring and swollen appearance. And she was beginning to lose vision. And if this patient had now been left at this stage, we know from the trajectory of our cases that she would become irreversibly blinded. So she had to go for emergency neurosurgery. And what we do for these patients is that we put a shunt drain, which is essentially a bit like a tubing or a hose pipe, from the ventricle of the brain, which drains into the abdominal cavity to rapidly reduce pressure down to save vision. It decompresses the optic nerve. So obviously this is a very severe case, but it also emphasizes, I think, that for some reason, some patients at some point will start to decompensate and their optic nerve can no longer handle even that mild degree of swelling. Now, the second thing that we know from my clinics is actually that headache is quite common. Headache is often occurs in the setting of raised brain pressure. If it's very severe, you can get very rapid onset of headaches. And the headaches that you tend to get on this graph here in red. So you tend to get a headache attack, a few days off or a couple of weeks off, another headache attack, and then the headache attacks get closer and closer together. And they often have a migrainous feel where they feel throbbing and the patient will feel nauseated. But what's also important in our clinics is that there are risk factors that make people more headachy. For example, if they've had previous migraines or they have a family history of migraines or they use a lot of opiate medications. And that sometimes in patients, even when brain pressure is returned to normal, if they've had problems for long enough, the headaches can remain really quite chronically for a number of years even after the brain pressure settles. And that's what we see here, these chronic background headaches with superimposed spikes. Now, from my reading and my discussions with colleagues, SANS does not appear to be a headache predominant condition. It's not well characterized or reported at all. There is a question of possible underreporting. Also, I think a question of whether the patients or the cosmonauts who are experiencing SANS are otherwise underlying extremely healthy, perhaps compared to the patients coming into my clinic. And also that the duration of the syndrome of SANS may be quite a lot shorter than what we see in IIH, and possibly with longer duration headaches may begin to become a feature. But I think it's quite complicated, and as yet it doesn't seem to be a major feature that's experienced in SANS. But the final awareness that has been really growing in our clinical practice is the cognitive aspect in raised intracranial pressure, particularly in IIH. And this is a study that some actually just nearly accepted for publication now, where we have looked very in a very detailed way at patients with raised pressure from IIH compared to controls that were matched. And we looked at a very large cognitive battery that included domains such as attention and working memory and executive function and short-term memory. And we very clearly saw that on a number of different domains, the patients who raised brain pressure in IIH were very different to the control participants. What was also very interesting was that this very much seemed to be related to the raised ICP. So, for example, we could reduce the intracranial pressure very rapidly by doing a lumbar puncture in these patients. And the lumbar puncture drains the spinal fluid and rapidly settles the brain pressure, but it's temporary. But when we temporarily settle brain pressure, we can actually improve these cognitive domains. The other thing that we noted was that over 12 months, if we saw the patients at the beginning and then again a year later, after we treated them and brought their brain pressure down, we again saw improvements in cognition. So these were clearly reversible deficits that seemed to be driven in part by intracranial pressure and fluid dynamic changes. So when you think more broadly about how what we learn from our terrestrial medicine and IIH may be relevant to what you see in your cosmonauts and in SANS patients, well, the duration of the mission seems very important because there is a potential risk of vision if the optic nerve changes a stage for long enough in the SANS astronauts. There is a potential for cognitive slowing. We don't see that currently in the data coming from the astronauts, but also the potential for risk of venous thrombosis, which again is much more serious. After missions, if vision had been impaired for long enough, there would be a potential risk of permanent visual loss and cognitive issues. And again, we've mentioned these white matter lesions on MRI, which in terrestrial medicine give a risk factor for future risk of cardiovascular disease and strokes. And again, there's a risk then in terms of future missions for the astronauts about whether they would be safe to fly again if they've had an experience of developing SANS during a mission. So how can SANS be addressed or treated? Well, there is a number of different literature out there. Sorry, I've got a helicopter going over. There's literature out there talking about lower body pressure, but for some, this is felt to be quite cumbersome and quite time consuming. And clearly the method of delivery has not been optimized yet, or the amount of time that it would need to be done for to mitigate SANS is not entirely clear. So I think there are also lines of thought looking at other alternatives to how to treat and modify SANS. So the lack of effective therapies, there are in general a lack of effective therapies to reduce brain pressure, and we find that in terrestrial medicine as well. We know if we see the diagram on the left here that when you have too much fluid, you can use treatments to reduce the amount of fluid to try and reduce intracranial pressure and to try and treat these conditions. But the trouble is that at present, the existing therapies have very poor efficacy, and that many of them wouldn't really be a suitable treatment to use in spaceflight. So for example, the drug that we use off-label sometimes in our IIH patients is acetazolamide. It has side effects such as paresthesias and nausea and tingling and low mood, but more seriously, a risk of becoming acidotic in the blood, of kidney stones, high eye pressure, and also the efficacy of this drug is very, very minimal. So in our lab, we started to think about new ways to manage brain fluid and intracranial pressure. And this sort of takes me on to the middle part of my talk, where I wanted to tell you about one of the new therapeutic pathways that we've been really looking at over the last decade or so. And this is looking at a pathway involving the GLP-1 receptor agonist, the glucagon-like peptide 1 receptor agonism. So GLP-1 is a small peptide which in all of us in normality is released from our proximal small bowel, that's the top part of our gut, in response to a meal. And knowledge of this pathway has been really instrumental in helping doctors develop existing drugs to manage diabetes, and also in some cases to be used at high dose to manage obesity. And so GLP-1 receptor agonism drugs are used all over the world, for example, liraglutide and exenatide. Where we started in the lab was the knowledge that actually the mechanisms that control fluid dynamics and fluid secretion in the brain, which occurs at the choroid plexus, is quite similar to how you control fluid secretion when you try and produce urine in the kidney. And in fact, the structure of these epithelium are almost a mirror image of each other. So the pathways are very, very similar. And we knew from the literature that GLP-1 pathway was quite important in the kidney to produce urine. So we made a hypothesis that GLP-1 would also be involved in fluid secretion within the brain. And we started off with human choroid plexus from post-mortem tissue, and we identified the receptor there. And then we worked back to our animal models and looked in rat choroid plexus with fluorescently tagged exenatide to identify exactly where this receptor was within the choroid plexus. And we saw it lighting up beautifully in the choroid plexus epithelium, the outer cells. And we saw that the amount of that receptor would go up when we treated it with the drug, the GLP-1 receptor agonist. And then what we did was we created a cell culture. So we moved to in vivo techniques. So we took the rodent, we took the choroid plexus out of the brain, we extracted just the choroid plexus epithelial cells, and then we grew a monolayer of those particular cells so that we could just study what happened in those cells. And what we wanted to know was once the drug attached itself to that receptor, what was the signaling pathway? We were able to work out that very much like other G protein couple receptors, when the GLP-1 attaches itself to that receptor, it increases this part of the pathway, the cyclic AMP, and it does that in a dose response. But most importantly, it does this to interfere with the actions of the sodium potassium ATPase. And that's important because that's the rate limiting step to produce brain fluid. That's the main ion transporter that makes secretion of fluid, what makes the gradients to make secretion of fluid. And then what we could do was we could put a blocker in this pathway, and we blocked this here, this yellow bit, PKA, with an inhibitor. And if we blocked it, we could stop that pathway going through, and we could reverse the effect on the CSF secretion. So using cell culture models, we can work out what the cell mechanisms are. What we then did was to move forward again into in vivo work into live rodents. And we have a system set up in our lab where we can monitor the brain pressure in rodents. And this is the normal brain pressure waves that you can see. And this was an exciting time in the lab because we were able to give our rodents either a placebo drug, which is in blue, or we could give in red the GLP-1 receptor agonist, which is exendin. And we could see that the drug rapidly, so within 10 minutes, and in a sustained way, reduced the brain pressure by about 45%. And then we could do that over a week. What we then did was what we'd often do with drug discovery work. We went on to look at how long the drug would last for. So this is our time course experiment. And we can see that one dose of the drug would last up to 24 hours in terms of managing brain pressure. And then in the bottom graph down here, we gave different doses. We gave a high dose and then a lower and a lower and a lower dose. And we wanted to get a dose response to see how much drug we needed to give to modify brain pressure. And again, we got a very clear dose response curve, which we can then use to understand how much drug we need to potentially use in human patients. And then the third part of our preclinical work was to test this actually in an animal model that had very high fluid secretion and very high brain pressure. So we created a hydrocephalus rat, and this has been done quite regularly. It's a very known experiment. You give an irritant into the back of the rodent's brain, into the cisterna magna with kaolin, and you get a hydrocephalic brain. And you can see that most of the rats had over doubled their brain pressure. And again, when we gave the drug this time, just the same pattern, we were able to rapidly and in a sustained way drop the intracranial pressure by about 45%. So this took us to the point where we had established a really nice pathway, a new mechanism of action to drop intracranial pressure in rodents. Now, I haven't included the data on the slides today, but we also went back and looked at some of the other drugs that we use clinically, for example, diuretics, acetazolamide, topiramate, and we looked at those in our animal models, and they weren't able to drop the ICP in a significant way or to the degree you could do with this pathway. So this was the pathway we took forward. And we moved that forward into a human physiology study. And this was a prospective randomized placebo-controlled trial where patients were given either placebo or one-to-one randomized to receiving the drug, the GLP-1 receptor agonist, at a clinical dose that we already use, which is 10 micrograms BD. The inclusion criteria was patients with IIH, and they all had active disease. So they had to have the papilledema and the raised brain pressure. And our primary endpoint was to see, well, how was brain pressure affected very quickly at 2.5 hours and 24 hours, and then also at 3 months after 12 weeks of dosing. We looked at a number of other things as well, including vision and headache. What was quite different about this trial was that we wanted to be very accurate with how we measure brain pressure. And I don't think we're going to have time to go into a discussion today about all the different potential ways that we can measure or have surrogate measures of brain pressure. But one of the most optimal ways to do this is actually directly by putting a probe into the parenchyma of the brain. It's a very tiny probe. It's about a 3mm burr hole. It's something that goes in place into my patients over a 10-minute surgery that can be done awake or asleep. And this can then give a readout of brain pressure for 1 to 5 years. So it can give us very long-term data. So what was really nice here was that we were able to give a dose of the drug and monitor in real time how brain pressure changed very quickly, and then to see what happened over a longer period of time. So here in a nutshell is the primary outcome data, and this is just coming through for publication, so it's pre-publication at the moment. But I can share with you to show you that the intracranial pressure was significantly reduced at 2.5 hours, 24 hours, and at 12 weeks. And although the graphs show data in millimeters of mercury, I've converted this in the orange box to a more clinically relevant measure, which is centimeters of CSF. And that would be a really useful, meaningful change in ICP of between 5.5 and 6.5 centimeters of CSF. One of the other things that I thought was really interesting about this very early human study was that we noticed things about what happened to brain pressure of patients ordinarily. And we noticed that as per previous older literature, the intracranial pressure rises overnight when patients are lying flat. And that's the black line. So brain pressure goes up and up and up the longer you're lying flat in bed asleep. And that's often why patients who are prolonged lying flat will wake up with morning headaches, for example. But in the patients that received the drug in orange, the drug was able to stop that progressive rise of brain pressure over the nocturnal period. We also saw that there was significant improvements in the headache outcome, the monthly headache days measured in our patients, and a trend towards improvement in the amount of painkillers that was taken. And then these here are a slightly different measure. The first one is visual acuity. Many of you may have done this when you've been to an optician and you read the letters down on the chart. So that's the acuity, and we showed improvements there. But importantly, the weight of these patients didn't change. And that was something that was really useful to know, because we therefore knew from this data that it wasn't an effect because of weight loss. This was a direct effect through reduction of brain fluid and not mediated through weight. So the drug safety. So the GLP-1 receptor agonist exenatide produced no what we call SUSARs, so unexpected serious adverse reactions. There were only minimal side effects, and that was in terms of nausea in these patients. We did have one serious adverse event, which was a patient who got thyrotoxicosis, but they were on placebo, so it wasn't related. And in general, these drugs are widely used, they're tolerated, they don't lower blood sugar in the absence of other diabetic drugs, and it doesn't cause changes in eye pressure or renal stones. So it's weighing up the benefits and risks of those drugs in the setting of my terrestrial patients, but how potentially it may also be useful for patients with SANS. So exenatide significantly reduced the intracranial pressure both rapidly and in the long term. It improved that ability to read vision down a chart, the visual acuity, and weight loss didn't occur because they weren't dieting. I want to move on now to the third part of my talk, which is more about how we monitor patients. And this has really been a revolution since I have been practicing, where when I first started training as a junior doctor, when we looked at the back of the eye and tried to monitor optic nerve swelling, we had to draw a paper picture in the notes of what the back of the eye looked like. And when you came to see the patient again, you had to look back at your hand-drawn pictures or at somebody else's hand-drawn picture. And it was very, very subjective to know if patients had changed. And the real revolution that's come through is the use of optical coherence tomography to quantify and to track. And it's growing in complexity. It was a technique that was initially used to measure loss of the optic nerve, for example, in glaucoma patients. And it's used all over the world, including in field hospitals in Africa and even on the ISS. And what has grown in sophistication is how we use this technology. So we started off with, you can see here, the green peripapillary retinal nerve fiber layer scan. We also do the scans of the optic nerve head volume, and we now also do scans of the macular volume, which can tell us a lot more about a particular cell called the ganglion cell, which is the one that dies when there's too much ischemia and causes permanent visual loss. So we can measure a number of different aspects of the optic nerve. And we've published just before Christmas on how we use this more in clinical practice, and I'm just going to go through some of that data. We took 101 patients with active raised pressure from IIH, and we divided them into the first cohort that had the intracranial pressure monitoring with the probe, so it gave us beat-to-beat ICP, and we had cohort 2 who we monitored the ICP more conventionally with a lumbar puncture. And we looked at these patients at baselines 3, 12, and 24 months. And the first thing that I wanted to highlight is how we think about the severity of optic nerve swelling. There's been a very traditional approach called the Frisson grade. And you can see the Frisson grade 0 is normal, and it goes up to a grade 5, getting worse and worse and worse and worse. And we can see quite clearly that the imaging technology of OCT can very carefully and very objectively classify the optic nerve into different grades. But this is the important and more interesting part. For the first time, we were able to show that intracranial pressure measurements taken with the brain probe very clearly and significantly correlated with the specific measures of optic nerve head height. And then we went on to replicate this in our second and much larger cohort and to build a model of the data. And what we were able to do using bootstrap surrogacy models is we were able to model that optic nerve head height, the papilledema, to try and predict what the change in intracranial pressure would be. And we did this with a number of different OCT imaging paradigms. For example, here on the next slide, you can see that we're comparing the traditional measures of the retinal nerve fiber layer against what we feel is the much more objective and useful measure, which is the optic nerve head central thickness. But what we've been able to do with this is not only to say from this non-invasive monitoring of ICP is to say if the pressure is high or low, but we've been able to tell you about the degree of change of the intracranial pressure. So for example, if you have a 50 micron change in your optic nerve head height, this will predict a 5 centimeter change in pressure. And then you can see again, if you had a 100 micron change of your optic nerve head height, this would predict a 5.9 centimeter of water change in your intracranial pressure. So a big advance for us, because obviously our patients don't enjoy having lumbar punctures. It's a really troublesome thing to do. So to start to make advances to be able to predict changes in brain pressure without the need for lumbar puncture are really important for us in terrestrial medicine. But of course, in the setting of monitoring or understanding brain pressure on the ISS, then that's also really relevant because lumbar punctures at present are not something that's possible during spaceflight. So my key messages today are to draw those analogies between the fluid shifts and raised intracranial pressure, and to say that although IIH is very different to SANS in terms of what drives and causes these conditions, the manifestations and how these conditions appear to the doctor are actually quite similar. And so we might extrapolate some of our knowledge of what happens to IIH patients to what may happen to patients with SANS, or to astronauts with SANS. The drug treatments for patients with IIH and other similar conditions have been really quite lacking in terrestrial medicine, and hence this drive and this need to develop new treatment pathways. And we are certainly now progressing to both funding from industry and funding from academic sources to carry out large phase 3 randomized controlled trials of the GLP-1 receptor agonists internationally and in the UK to try and bring those through for licensing for patients with IIH. But again, this offers a potential treatment that may be thought about in the setting of spaceflight and SANS. And then my final, and I think for me, one of the biggest advances in our care currently has been how we monitor patients, knowing that we can monitor patients in our clinic now using OCT to find very tiny changes in optic nerve swelling, whether it's getting better or getting worse, and using that to judge clinical care and progression, but also that ability now to use the OCT monitoring as a surrogate measure to help us predict what's happening to brain pressure, to reduce that need to actually do invasive brain pressure monitoring. So that's the end of my slides today, and it just remains for me to thank very much my group in Birmingham. I'm very lucky to have a wonderful group of translational researchers, right from the clinical bench and the laboratory bench through to the clinical practice and clinical trials, and a number of medical students and basic scientists who work together to really think about the intricacies and the knowledge around how we can understand and modify brain fluid and intracranial pressure. So I have left plenty of time for questions, so I hope that's suitable.
That's wonderful. Thanks so much, Dr. Sinclair. We appreciate the presentation. It was outstanding. And please, if anyone has a question, we can track it with hands being raised. I think it's probably the most efficient way to do it. So please feel free to ask a question, and let me recognize you by seeing your hand raised. Okay, looks like, let's see. Dr. Polk, please.
Thanks, Ed. I just want to first thank Dr. Sinclair for her time and her presentation. And yeah, I've known Alex for a while now. Alex, in your look at this data, is the look or the feel of how patients react supine equivalent to what we're seeing in spaceflight? Are we seeing that same type of increase gradually in ICP that you see when you are supine, and could we potentially see the same impact with exenatide that you would see in those patients to where it flattened that increase in ICP?
No, I think that's a really wise comment on the supine ICP. So I think that's exactly what we see. We have a more detailed graph, which I didn't include, which shows that if you just lie flat for 5 minutes, your ICP is pretty stable. But once you get to 30 minutes, you do get a significant rise. And by 3 hours, and certainly by overnight, your ICP is dramatically higher than you were at the beginning of the night. And so if you don't have that ability to move between lying and standing during space flight, that is going to have significant implications on how brain fluid dynamics and intracranial pressure dynamics alter. We don't know the full mechanisms. We're starting to explore what is occurring during that time of rising ICP. But irrespective of the mechanisms, we understand that if we lower brain fluid, we can lower intracranial pressure. So the exenatide use, we are moving that forward certainly in our terrestrial patients, and I think it would be a very exciting opportunity to use in spaceflight. It's got a really good side effect profile compared to anything that we use so far. And that initial data that we've got has been extremely reassuring to show that we can very rapidly and in a sustained way drop the intracranial pressure and modify outcomes. So yeah, I think there's a big question mark there as to whether that would be helpful.
Thank you. Dr. Brunstetter.
Hi, good morning, Dr. Sinclair. Thank you so much. That was an extremely interesting, informative presentation. I'm Tyson Brenstetter. I'm the clinical lead for SANS from a visual ocular standpoint. Pleasure to meet you. I've heard your name many times. I love the presentation. I have no questions. I think you're spot on. I enjoyed every minute. I would like to make a couple points, though. That I think goes right along with what you were presenting. First of all, it's great to see that you are driving towards an objective measure of the optic nerve anatomical changes using OCT. That's one of our goals as well. We are transitioning over, we're using a delta total retinal thickness immediately surrounding the optic nerve head as one of our primary measures. And it seems to be working well, certainly much, much better than the Frisson scale. I think you kind of alluded to the fact that maybe Frisson scale isn't the most appropriate method. But second point is that the primary questions of interest for us, I think really are, number one, what role does intracranial pressure play in the pathophysiology of SANS? Number two, does intracranial pressure rise during spaceflight, even slightly? And three, would reducing intracranial pressure during spaceflight mitigate SANS? We don't know the answers to these questions yet, but I think these questions really drive our need to measure intracranial pressure during spaceflight. That's the only way that we're going to know truly without a shadow of a doubt what role intracranial pressure plays in SANS. And these answers will really drive the work in the future. Like anyone else, we have limited capabilities, capacity, limited personnel. And so if we can determine that intracranial pressure is the factor, then we can focus our efforts more appropriately. Or on the other hand, if we find that it's maybe not so much, we can focus in other areas. So apologize, I really didn't have questions, but I did want to make those points. Really appreciate your time and nice to meet you. Over.
No, thank you. No, that was really interesting to hear. And no, I completely agree that knowledge of exactly what happens to brain pressure is fascinating, both for you and for us, for me looking in from the side. But I guess one of my other thoughts would be is that whether brain pressure is elevated or not, we definitely have evidence that fluid is accumulating in the back of the eye and around the optic nerve, the MRI evidence of fluid accumulation in terms of CSF volumes and brain volumes. So there's certainly a fluid component to it. But just like in IIH, we haven't been able to, after 100 years of research, really nail down if this is CSF hypersecretion or reduced absorption at the arachnoid granulations or problems with compression of venous sinuses. And we kind of have gone around in circles as a specialty for a really long time to really nail down exactly what it is. And so we've just come around the full circle now just to try and reduce brain fluid in general as a way to mitigate that. So, I would hypothesize that potentially if you were to reduce brain fluid, you could mitigate SANS, potentially irrespective if it was high brain pressure or if it was just a fluid shift. So that's perhaps a slightly different take on it.
Brian Rodriguez.
Hi, Dr. Sinclair. Thanks so much for this presentation. This was awesome. I just had one question. I was kind of curious. I know that you said the side effect profile for these types of drugs is relatively low in your study, but I was just wondering if we were to implement something like this for astronauts, what would be the most concerning side effect that flight surgeons would need to be on the lookout for in astronauts taking this medication on the ISS?
Yeah, absolutely. So it would be nausea. So there would need to be a discussion about whether you would start it as a preventative to stop SANS from occurring in the first place and progressing, or whether you'd start it very early or whether you'd start it later. Typically in patients, we try and intervene really early as soon as we see any sign of the disease that could potentially be visually threatening. So I guess the main side effect would be mild nausea. I understand from when Dr. Polk presented in our institute that there was already quite a lot of nausea in the first sort of week or so of acclimatization to space flight. So I think it would be similar to that, but probably not as bad. In all of the patients in our trial, they did experience mild nausea, but none of them stopped the drug because of the nausea. And to put that in context, we ran a previous trial with acetazolamide where 48% of patients discontinued the drug because of the side effects. So it's very different. And then the second thing I'd say is that it can be an appetite suppressant. So if it's used in conjunction with a low-calorie diet, patients will lose weight on this drug. But in our study, people were not told to go on a low-calorie diet and so did not lose weight. So you would just need to make sure that normal nutrition was implemented and people were advised to eat as they normally would do during spaceflight and not diet, I guess.
Hey, Dr. David Alexander.
Yes, thank you very much for your presentation. One of the things that I've been looking at on board is chronic CO2 elevations as well as acute CO2 elevations. We know that earthbound CO2 rises, especially above 10 to 20 millimeters of mercury arterial, have a tendency of developing papilledema, as well as since CO2 increases ICP production, as well as systemic hypertension. And we have linked headaches aboard the ISS directly to CO2. And since ICP pathology is part of the CO2 pathology, I was wondering if you can opine that and possibly ameliorating that effect as well on ICP.
I mean, I think it's difficult to tie everything together. I think my first thought as a doctor would be, well, I don't want to make any potential acidosis any worse. So I wouldn't want to give a drug like acetazolamide that could potentially exacerbate that situation. In terms of whether a drug to reduce fluid secretion would also improve the optic nerve edema if it was partially driven by CO2 elevation and acidosis in that mechanism, I would hypothesize that it would. But I guess that I don't know if you have got any planned animal studies, but this would be something that you could model really nicely in vivo. I'd be very fascinated to look, for example, in my animal models, to put them in a situation of high CO2 and use our telemetric ICP monitors in the rodents to try and unpick a little bit more about the difference between how much CO2 can affect ICP compared to other mechanisms. So I guess I would go back to the bench to try and unpick that one.
Thank you.
Dr. Bill Tarver.
Good morning or good afternoon, Alex. Thank you so much for today's talk. It's wonderful to have you in this group. Thank you, JD, for bringing us all together with Alex's team. Pathophysiology, we just don't know. And we know that our group of patients in the astronaut world are very different than the IIH world, right? Males mostly, but we do have females affected. For everybody to understand, females are affected as well. Headaches, your team put out a wonderful article about headaches, and for our colleagues here, just to understand, there is not really a stereotypical headache in an IIH patient, right, Alex? Do you want to comment on that real quick?
Yeah, I do. And I think it is a really curious thing, Bill, because some patients do not get any headache in my clinics. It is rare, but some don't get any. Some people are very, very headachy. And I think the risk factors for a lot of headache are if you had childhood migraine, if you were a migraine sufferer, or if you had a strong family history. And I just wonder if your astronauts are probably not going to be selected for flying if they're probably prone to recent or to frequent migraine attacks, like once a week anyway. So the patients that are really migrainous and really headachy tend to have had a previous history most of their life of being very, very headachy. But there's a curious relationship, because when brain pressure goes up, or they do get the headaches, and when we can do a lumbar puncture, we can bring the headaches down. But after a bit, if you leave the patient like that for long enough, they get this situation of what we call trigeminal vascular activation, so activation of the brain pathways that drive headache. So even then, once you bring brain pressure sort of back to near normal, the headaches may well continue just like they do in a migraine. And the headaches are very variable. Like you were saying, the phenotype is not what we learned in medical school of vomiting and always in the morning and worse when you bend. It's very much like a migraine patient where it comes intermittently and then you start to get a background headache all the time. It's just a muzzy head with some superimposed bad days where you feel the throbbing pain and the nausea.
Yeah, and I think that's very important information for all us to be aware of. We know our astronauts get space fog when they go into space, but we don't know if it's just the whole environment of going into the zero G and fluid shifts and all sorts of things going on. But we do screen them pretty well for headaches before they get sensitized to SANS, Their biggest concern once they're astronauts and they're actually sensitized to space medicine and all that is loss of their certification to go fly. So it's a real challenge to work with them, get LPs done, that sort of thing, because the last thing in the world they want to do is volunteer for something and then lose their flight status because of it. So it's challenging for us. But we do get good information on headaches, I think, before they get sensitized to this, and those histories aren't present in our folks. So I have multiple things, but I'll try to get through them quick. The medication, this is great. There is no way our specialist would advise any of our folks to take acetazolamide, not in the doses they would need for real IIH cases. So I'm very happy to see this research going on with this medication, and look forward to publications coming out. This has a much better track record, let's say, for side effects, and it's possible our astronauts would accept this over, acetazolamide. They would actually get some decent treatment levels. And that gets to the IIH or the ICP levels. We just don't know what they do in space. We have lots of we have the hypotheses. So getting the data to fill in there, so we don't know what normal cases when they come back. We've never done LPs on anybody who's normal. They've all had disc edema, and that's what's driven us to do an LP. And the studies with OCTs, just one other, congratulations. This is where we're going. Tyson mentioned it. Studying the central optic nerve head using OCT data, objective data. For us, we use the total retinal thickness, and we're looking at a change of 50 to 55 microns is where we think you hit the Risen grade 1 optic disc edema.
Yeah, if I could just sort of comment on that. So we do use total retinal thickness in clinical practice sometimes. I tend to use it in really severe papilledema where the demarcation between the retinal nerve fiber layer and the layers below becomes blurred because there is such a degree of papilledema. But if I want to be super accurate and spot things earlier, I tend to just do the retinal nerve fiber layer central thickness. So rather than taking the total, which is a much bigger cut, I just do the bit that can actually swell. Does that make sense? So that's why we've moved to doing central thickness just on that particular, on those particular histological layers. Although, like I say, if it's a shunt patient, we go back to doing total retinal thickness. But it's a really nice technique, and I think for us now, it's having the confidence, even when there is a very small change. So I guess what I would be thinking in the context of space is as soon as you saw a very small change on OCT, if you had a treatment, you'd be wanting to use it early to prevent progression. Yeah.
And then I just have one last thing. So Ed, you can take it away after this. Question for you, and that's related to doing an LP. So we know LPs have, their challenges. So what's your confidence in a measurement that's taken just at one lumbar puncture session? And how do you get to a confidence in what the ICP really is?
Yeah, no, it's a good question. And I haven't brought it out today, but we've run, I think, 3 trials now where we've used lumbar puncture assessments in major trials as an outcome measure. So we've had to get really certain about how we do it. And you're quite right that if you don't do it in a very standardized way, or if your operator is not really skilled in the technique, you're going to get false data, which it plays havoc, particularly if you've got small sample size like you will do in your astronauts. So we have a standard operating procedure that we really strictly follow, and we have very strict training. I do them all ultrasound guided. We do them with a pencil point needle, not a cutting needle, to minimize risk of low pressure headache. So for example, using a Quinky cutting needle, the low pressure headache risk is 16%. Using a pencil point needle, the low pressure headache risk is 0.03%. So it's markedly different. We use ultrasound to place the needle in the right place, and we have a protocol that you always have to be lying. Your knees have to be extended at 90 degrees so you don't compress your abdomen, breathing regularly, and you have to wait at least 2 minutes for the fluid level in the column to settle before you take your reading. So I think it's all about the training and the standardization of your medical team doing those, or even a nursing team. We train nurses to do these for some of my trials, but they just have to do them regularly and in exactly the same way. But you're quite right, it is a spot reading, and that is why in my small study, we use the brain pressure monitors, because we can get really, really accurate data that way. But I still think it's pretty good using a lumbar puncture.
Great question. Thanks. And great answers, of course. And we have a question from Dr. Mary Van Balen.
Good morning. Thank you for a really interesting presentation. You sparked some interest in my head to ask you kind of a related and maybe a bit unrelated question. I am the lead for the Lifetime Surveillance of Astronaut Health program. So I'm an epidemiologist, an occupational epidemiologist by training. So my questions are going to be along those lines. And particularly speaking on OCT, when we look for literature and try to characterize normal findings in the population, we often find populations that have presented for care of some sort and undergo an OCT or undergo an MRI, et cetera. But I'll speak to OCT in this situation. What I'd like to be able to do is first ask you, are you aware of populations that would have a cohort of normal, where these findings in normal have actually been characterized, so we would have potentially a comparison population for the findings that we're seeing in healthy astronauts? Would be different than your population, obviously. And based on your nod, can I contact you and get some insight from you post this presentation?
Yeah, absolutely. It's a lovely question. And I think it's something a lot of us have been aiming for. So, and the word insight, I guess, was the critical one. We have a program called Insight, which is run from Birmingham. It's in collaboration with Moorfield, which is the big London hospital, and Google DeepMind. I don't know if you're aware of that, the sort of the pharma coming, or the industry coming in. So essentially, there's been a big collaborative platform that's been set up between the NHS and Google DeepMind, where the OCT scans from tens of thousands of patients are being put onto a platform. And we use some of that for our research in what we call oculomics. So, you know, there's going to be huge developments now about being able to predict things like Alzheimer's disease and cell loss from OCT scans and big longitudinal epidemiology studies. But just like what you're saying, as we start to go into looking for longitudinal cohorts and also computer modeling and AI, which we've started to get involved in with the OCT, you need your normal cohorts and your diseased cohorts. So yeah, definitely reach out. There's very big cohorts that have been assembled now in the cloud, if you like, for these types of collaborations.
That's good to know. I will reach out to you. Thank you.
Thank you. We have time for one more question from Dr. Emily Stratton.
Hello, thank you for the talk. I just had a question. I'm interested in how often you use ultrasound versus OCT to diagnose IIH.
Yeah, no, it's a really good question. And it's a debate that I have quite a lot with my emergency room doctors, because the emergency room doctors often use ultrasound to tell me that they think that the pressure is raised. And then we tend to use the OCT more. And if you look at the review of the literature and also our clinical experience, the reason that we've moved so strongly towards OCT is because it's so much quicker and more objective. So I don't know if you do ultrasound scans, but they are a little bit more time consuming, and it's very user dependent to get the B scan in exactly the right place on the orbit and get the cut across the right place to get your measurements of the optic nerve distension correct. And it's always also this interpretation of what's normal, because everybody, of course, has fluid in their optic nerve sheath. So you're then just making a measurement of something that's a bit more than normal. So I think that we use it in our pediatric setting to say pressure could be up or it could be down, but it can't give us that granular quantification of to predict brain pressure that we can now get with the OCT. So I would say it's coarser. Does that make sense? Or yeah.
Yes, thank you. Thank you for going over that.
Great. We've come to the end of our session, and I would like to thank you very much, Dr. Sinclair, for the presentation today and the subsequent discussion. It's been very informative for all of us, and we really appreciate the time you spent with us today.
No problem. It's been a delight to talk to you all. You're a very interesting bunch.
I'd like to thank Rachel Fowler once again for setting up the session and troubleshooting everything. And Rachel, I'd like to offer you an opportunity to comment if you have any other comments.
No, sir, no comments from me. Thank you.
Great. Thanks very much. We look forward to seeing everyone at the next session. Take care.
Thank you, everybody. Bye-bye.